Well, let me begin by saying thanks to Sinéad for organizing this session. We often at these conferences have a lot of talk about money, how to repair the broken financial system, how to get us out of debt into recovery. But what sometimes gets lost is the human face of the economic crisis. That ordinary people are suffering. People have lost homes, they've lost jobs, many remain mired in debt, and now at a time when they look to the government for help the most, in many cases, more and more, they're being told they must do without as budgets are scaled back and extensively cut. What I want to do in my talk is focus on how will these drastic changes affect health, and what can we, in a time of austerity, recommend to do to help make a difference. And before I begin, I'd just like to give a brief note of thanks to my colleagues, Dr. Martin McKee at the London School of Hygiene. Mostly, when I'm at these conferences, I'm talking to just doctors and have heavy data-packed messages. And usually, one, if not all, are at the conference too. So I'll just bear with me as I go through a lot of data in the talk, some of it medical in nature. So, before I begin, I should point out there are two broad views on how the crisis will affect health. A lot of doctors and people working in public health paint a dismal picture, expecting to see more stresses, more anxieties, people saving money on food, eating less nutritious meals with risks of diabetes and obesity, potential heart disease, and stresses and anxieties leading to mental health problems and disorders. But on the other side, there's a group of social scientists, largely economists, who a bit tongue-in-cheek say that, well, recession could be a lifestyle blessing in disguise, pointing out that when people go through hard times, they may smoke less, drink less, walk instead of driving. And these could have real health benefits when economies collapse. So what I'm going to do is try to turn back to past crises for clues. We heard Professor Galbraith invoke two major crises, the Great Depression, which many analysts have looked to for insights of what will happen, what we should do in this crisis, and the collapse of the Soviet bloc. And I'll just give you a helicopter tour of what happened to health from our research in both of those crises. So let me just dive right in. The first of these, the Great Depression. Black Tuesday, October 1929, a speculative market bubble burst, leading stock markets to crash, GDP to plummet by a third, in the US, unemployment to reach a quarter of the workforce, and in Europe, creating conditions of economic hardship that ultimately paved the way for fascism in World War II in Europe. And at the time, much like today, economists believed the good times could go on forever. Here's Irving Fisher saying stock prices have reached what looks like a permanently high plateau, but alas, it could not continue. And what may come as a surprise to those of you who learned about the Great Depression like I did, through iconic images of bankers jumping out of windows, is to know that even though suicide rates rose, overall, mortality rates fell during the Great Depression by about 10%. Reporting in the New York Times, the head of the American Medical Association exclaimed that never before have there been such satisfactory health conditions in the US as in the early part of the 1930s. So this seems to lend some support to the view of those who say, well, maybe recession is good for us, we shouldn't be worried after all. But not so fast. There were a couple important things going on at the time which give us some important clues about the current situation. So we were able to take data from US cities at the time, and we did find, indeed, as the economy collapsed, here's a picture of all causes of mortality, rates falling and rebounding, starting to rise again in 33. And two important things at the time, as I mentioned. One was the New Deal, the birth of the US social welfare system, which greatly expanded financial relief to the unemployed and led to the creation of much public infrastructure and social welfare services that continued later. And the second important factor was that there had been a decade of prohibition on alcohol, with one of the most important women's movements in the US with slogans that and still fear to this day, lips that touch liquor shall not touch ours. Needless to say, even though it's possible to flout prohibition through speakeasies and other illegal means, it made it a lot harder for desperate people to access alcohol cheaply and readily available. And when it was lifted in 1933 as part of an economic stimulus measure, you can see the change in death rates from liver cirrhosis. The consequences were never fully assessed. That brings me to the next crisis, which was mentioned earlier, that in Eastern Europe, where this time, too, GDP plummeted during the transition to capitalism in the early 1990s by about 1/3, largely a similar magnitude as that observed in the Great Depression. But this time, there was a devastating mortality crisis. About 3 million excess deaths. These are deaths over and above historical trends, making it the worst mortality crisis in a peacetime period in the past half century. And there were many differences in the type of economic depression that occurred, but I'd single out two important ones. The first was that a far cry from Prohibition. The Soviet Union had a legendary drinking culture, and as the transition happened, new entrepreneurs flooded the region with cheap industrial-grade alcohol that was unregulated, especially pictures of these surrogates. These are aftershaves and perfumes that are marketed not by their scent, but by their flavor, like this lemon-flavored cologne. And of course, they're in a flip-top bottle, because why would you ever need to seal it again? I can assure you, they're absolutely vile. If you look, the second important point is that not just alcohol, but in contrast with the New Deal, the post-Soviet reformers set to shatter the cradle-to-grave Soviet welfare system. So instead of expanding social welfare to cushion people through hard times, many of those supports were withdrawn. And in detailed studies we've done in the region, perhaps inevitably we've seen there were winners and losers, where you can see here the chart of Slovenia and Poland. Life expectancy steadily improved over the time, whereas if you look in Russia and Kazakhstan, you see the pattern of a devastating fall in life expectancy. And what we found in our work is that those countries implementing more radical and rapid market reforms, on average, had greater rises in short-term mortality. And this can be seen in a contrast of Russia and Belarus, two otherwise similar countries that since the 1960s had been following a similar roller coaster trajectory in health. But for the first time in the early 1990s, upon the introduction of rapid market reforms in Russia, these two countries began to diverge, where you can see here mortality rates rose by about 80% in Russia, whereas in Belarus, critiqued for transforming very slowly, mortality rates continued along the path they had followed. Another important episode of the post-communist case was that may have some resonance here, is that some countries, to deal with their restructuring and debt problems, looked to the International Monetary Fund for support, and with it signed up to strict conditionalities on government spending, and with it, investments in health, in nurses, doctor salaries, and infectious disease control programs, among others. And what I've got here is a graph from a study that we published showing the diverging trajectories from the early 90s of those countries which borrowed from the IMF and tuberculosis, and those which did not borrow from the IMF, which largely continued along the path they followed. And we found those that did borrow from the IMF had much steeper cuts in government spending on health by about 8%, greater reduction in doctors, and less rollout of the recommended programs to combat tuberculosis and drug-resistant strains of the disease. So just to recap some of this data that I've thrown at you before moving on, we've seen a few important insights about how financial crises matter for health. The first is that there are the greatest risks when economic changes are rapid and uncertain. The second is that people are more exposed to the shocks when social welfare is weak and social cohesion, membership in social organizations is low. And the third is that the crisis is worse when drugs and alcohol are easily available, making it easy for desperate people to harm themselves and others. And that was the backdrop for a next study we did, looking at what happened to health in Europe over the past 3.5 decades, including Ireland. And in this study, we weren't breaking any new modeling ground. We just looked at peaks and valleys and measures of economic output and unemployment, with peaks and valleys in various diseases, mortality rates. And what we found was broadly similar to what we've seen in past crises, that on average in Europe during recessions, suicides tended to rise and traffic accidents tended to fall, plausibly as people drove less. And as a result of these two offsetting, there was no overall effect on mortality rates. And what we wanted to do here, though, was to go a step further, to see, is there anything you could do about the risks of intentional violence, suicides? And it's often claimed that social welfare can make a difference, and so we sought to model this to see whether it really does. We looked at data on social welfare spending from the OECD and captured measures such as family support programs, housing subsidies, cash benefits to the unemployed, active labor market programs, and programs to help people get back on their feet, find jobs, and old age pensions and survival benefits. What we found, it could broadly be depicted in this picture, a tale of two countries, Sweden and Spain, in their recessions. I know this may be a little hard for you to see in the back, but what I've got here in Sweden is trends in unemployment rates. You can see in the early 1990s, Sweden's banking crisis, where unemployment rate shot up by about 10 percentage points in a very short period of time, which is more than some hard-hit countries in Europe have faced today. But if you look at suicide rates here, which I've plotted in blue, it's as though nothing had happened. Suicide rates continued to fall steadily. Sweden was able to decouple its economic shocks from the health of its population. You see a contrasting picture in Spain, where the peaks and valleys in unemployment broadly coincide with the peaks and valleys in suicides. And when we looked across the region, this is what we found, that investments in particular in labor market programs, active labor market programs, reduced the risks that we saw of economic shocks to suicides. And we found similar benefits for family support programs, including early childhood development initiatives and maternity support. We found no benefit of giving cash to the unemployed, which psychologically is intuitive. If you just replace incomes, it doesn't give people the same hope or a reason to get out of bed in the morning. And as the risks are largely economic, it also didn't surprise us to find that investments in healthcare were not particularly protective. And at high levels of investment in active labor market programs of about 130 euros per capita, we found that economic shocks were decoupled from suicide trends in a population. That is, at sufficient levels of investment of effective services, the risks to health of a faltering economy would diminish. Okay, but you've seen social epidemiologists perhaps before issue a lot of predictions, in many cases wrong. What's actually happening? And here we can see early data that are bearing out our predictions. We've seen suicide rates rise in the UK, and in the US, we've seen major drops in road traffic fatalities, as one report puts it, highway deaths declined to a 60-year low. The report attributed it to US government interventions to promote road safety, but it likely has much more to do with the recession. It's happening to such an extent that cardiologists in London are telling me they lack organs for transplants because the road traffic deaths are their crucial source of supply. And this is creating a different set of backlogs and knock-on effects to where when I now go to Delhi, I'm hearing horrific stories of farmers getting more money for giving away organs to feed the black market around the lack of supply. And here's a picture of what's happened in Ireland pre-post-crisis. You see in general a steady decline in suicides until about 2007. In overall on average in the EU. Ireland looks more like a roller coaster. It dropped in 2007, but then began to reverse in 2008. And as I understand it, the 2010 data are just coming available, and they show that suicide rates remain elevated from pre-crisis levels. A natural comparison country for Ireland might be Portugal or Spain, or even possibly Greece. Just hot off the press here in The Lancet, we did an analysis of what has happened to health in Greece, where we see a 52% rise in HIV infections. Half of this, it appears to be coming from a rise in prostitution and associated unsafe sex. The other half appears to be coming from injection drug use. There was about a 20% rise estimated in heroin use, and needle exchange programs to limit the risks of needle-based transmission seem not to have been able to keep up with demand, and there's been a tenfold rise in injection drug use linked HIV spread. Greece has a universal healthcare system, which makes going to the doctor free at the point of service, unlike Ireland. But nonetheless, we have seen rises in people not going to the doctor despite feeling that they really should have done so. And this seems to be happening for a few reasons. There have been about 40–50% cuts in hospital budgets. Several small clinics close to people have closed, so people have to travel farther to get to the doctor. And the other problem is doctor salaries have been slashed, and this has exacerbated some corruption in the system to where now we're seeing reports of doctors taking bribes from patients to jump queues. And another problem has been that there's been about a 40% cut in sickness benefits for more advanced services. And as another picture of society in decline, the rise in suicides has been about 60% overall since the crisis, much worse in Ireland, and homicide rates have nearly doubled.
David, just a few minutes.
Just a few minutes. Yeah, I'm coming to a close. This poses a warning for Ireland is different, but for what could happen, as these are effects not just of the crisis, but now seem to be a direct result of austerity. So let me just close with a figure that captures how I've been feeling as a result of the crisis. What I've got here is an iconic image of the US, Uncle Sam, pouring out pork, this is the cash, into a trough which is being chomped on by corporations, banks, and industry, the benefits of recovery. But behind the fence, which is a little hard to see, is a pig labeled the rest of us. And that's often in healthcare where we stand. We're picking up the pieces after all social supports have failed. We've seen bailouts for the banks, budget cuts for the rest of us. Every crisis is an opportunity, so the saying goes. Somebody will take advantage of it. There are concerns that those who have an ideological agenda to shrink the role of the state already have. The least that we can do as economists, researchers, concerned people is begin to document the real life stories of human suffering that are happening now and to get those in the public debate. Thanks very much.
Hand you over to Sara Burke.
My title was based on a report that I was co-author with our chair, Sinéad, that I did. We did in recent work for TASC called Eliminating Health Inequalities, and there's copies of the report out there for you. I'm not going to go through it in, you can hear me if I'm not behind the mic.
No?
Yeah. I'm not going to go through it in detail, but much of what I'm going to say is drawn out from it, and some of it is more information that's come to light since we wrote it. The report came out of the work of a TASC Health Inequalities Advisory Group, which was chaired by Joe Barry from Public Health and Trinity. Ruth Barrington, who's here, was part of the group. Fergus O'Farrell, Lorraine Mulligan, Jane Wild. It's always unwise to name people because you leave anyone out, you can leave anyone out. And it was an attempt to put in an Irish context some of the work that's gone on in an international context around health inequalities. think Sinead and I would both admit it was a pretty quick and dirty piece of work to try and put, I hope Ruth's not insulted by me saying that, to put this issue out there and on the agenda. So thanks to Sinead and also to Tom and Dara in TASC, who did lots of the backroom nitty-gritty work for it and don't get any of the credit. Where are we going? As I said, it's drawing on the work of the WHO work from the Social Determinants Commission, and this is work done on health inequalities in a global context, but it very much frames its work that social injustice is killing people on a grand scale. And because it's global, it documents a lot of the inequalities between the developing world and richer countries, but it also talks about that it's not the level of wealth or income in a country that counts, it's the distribution of that wealth and income that impacts upon health and health inequalities. And one of the figures it draws out is in relation to New Zealand, which has a GDP half that of the United States of America. This was pre-crisis figures, 2008 figures, but has a life expectancy, an average life expectancy of 1.5 years. And I say that just to make the point that life expectancies vary, but what the WHO work and what we're trying to show in an Irish context is that economic and social policies matter. So we can make policies that either make those inequalities worse or indeed better. And certainly when we were doing the work, it was in the context that in Ireland we've never had a public health policy, which is when you tell European colleagues this, they don't really believe it. But we've never, now actually the government and the Department of Health are now developing a new public health policy. And certainly for those of you interested in this area, there's a call for submissions, and it's something that I think is worth really trying to influence. And we've certainly never had a policy direction around inequalities in health. We've never really had a policy direction around inequalities in health services, let alone inequalities in health status. So it was in that policy vacuum that the work took place. We luckily, because, and I was trying to explain some of this to David yesterday, that we really have a huge dearth of data on health and health status and inequalities in an Irish context. But the CSO produced figures published in December of last year, drawing on census 2006, showing the impact of area of deprivation, social class and education on life expectancy. And this is just one of them, showing the differences between the richest, women in the richest areas live till 82.7 and women in the poorest areas live till 83. So just a 3-year gap based on area of deprivation. But for men, that gap was, I think, 5.7 years. And also more, and it shows those gaps no matter whether you measure education or social class or area of residence. And it shows this sort of scale throughout, so that while poorer people are where your area of residence is or your education live shorter lives, there's this consistent social gradient no matter what measurement you use, with the gaps between, this is the social class measurement, professional women and unskilled men, there being nearly, I think, a 12-year gap there in difference of life expectancy. So really huge gaps in life expectancy between men and women, between rich and poor. This is work done by the Institute of Public Health, who have been trying to gather some of the health figures rather than just the death figures. And this is the prevalence of angina and heart disease across areas of deprivation. And again, you see just very clearly for men, for women, for every age, this consistent gradient in health, with people in the poorest areas experiencing the greatest burden of disease. And they've done a similar piece of work for diabetes, pretty much showing the exact same gradients in inequalities. And of course, the issue of childhood obesity. And again, childhood obesity doesn't happen in a vacuum. We need to look at the causes of childhood obesity. But with public health specialists in that area now saying that children now may expect to lead shorter lives than we do because of the prevalence of obesity. And again, we're beginning to get data on this in an Irish context. The Growing Up in Ireland survey, which just published stuff on the health of 9-year-olds, shows that chronic diseases among 9-year-old children were 3 times higher for children in the poorest areas than in the richest areas. So that inequality is starting at a very young age and being very hard to do anything about. And certainly for me, being involved in the TASC work, the real benefit was that TASC brings this economic lens to it and this economic inequality lens to it, that health inequalities are largely influenced by the structure of the economy, and that our economy has perpetuated, and economic policies has perpetuated those inequalities rather than address them. And then more recently that our banking policy, and we heard Tom this morning talking about the what do they call promissory notes. I find that word very hard to say, but that this year we'll be paying 3 billion in promissory notes to Anglo, and next year we'll be paying 3.3 billion in promissory notes to Anglo. And just those notes alone are 6.5 billion. The amount that takes out of what we can spend on other areas that could improve people's health and reduce inequalities. And we did have this policy. Oh, Jesus. How do I go back? There we go. Oh, yeah. This policy, this is our tax take. This is from the report, slightly updated, I think, of Ireland compared to the EU 15. And what we saw during the 14 years of Fianna Fáil PD rule was this decreased tax take. We increased social spend, but still comparatively it is much lower than the European average. And then we had this crisis fueled by a whole myriad of different components, again, which have been referred to this morning. And really what's in the EU, IMF, ECB memorandum reinforces these previous policies. In 2009, 14% of the population were at risk of poverty. That meant living on €230 a week, less than €12,000 a year. And what we had seen is that level of poverty had reduced significantly. It had gone from 21% in 2001 to 14%, this is the at risk of poverty, in 2009. And we also know that if social transfers or social welfare weren't included, if people didn't have access to that, that 46% of the population would have been at risk of poverty. So that's a huge difference between 14 and 46%, again showing that social welfare, social protection measures matter in protecting people from the harshest consequences of poverty. And what we've experienced in the last few years is this huge growth in unemployment, going from 4% or virtual full employment to over 14% as it is now, with 304,000 people unemployed, and also this big shift in the age profile of the unemployed, but also the long-term unemployed. And long-term unemployment is now nearly, I think, 60% of all those who are unemployed for longer than a year. That's that one. And then this is around disposable weekly income, and again this is taken from the 2009 EU SILT work, and it just shows the big difference between the bottom fifth of the population and the top fifth of the population in terms of how much money they have to spend. And what we've seen in government actions over the last 3 emergency budgets is this cutting of, go back to it, these cuts to income, greater levels of people out of work, unemployed, cuts to social welfare rates, rises in levies, and then these increased out-of-pocket expenses, which is why this is important, because people, the poorer people, have less money to live on, and yet they've more things that they have to spend their money on. And this is particularly true when it comes to the health system. What we've seen right through the crisis is this increased demand for health services. We have a growing, but that's not surprising, we have a growing ageing population, significant population growth, a baby boom, people living longer, a greater burden of chronic diseases. So the health service, despite a significantly declining budget and fewer staff, is providing more care to more people. About 2 billion has been taken out of the health budget in the last 2 to 3 years, about 6,000 staff taken out of the HSE staffing quota, and probably the same amount yet has to come out of the system. We're seeing increased rationing, so they're curtailing, and often not very obvious. We're not even being told that stuff is being rationed. And pretty much, despite the political rhetoric that waiting times are getting better, actually, if you look at the figures, in most cases, people are actually waiting longer than they were a few years ago. The quarterly National Household Survey, quarter 3 in 2010, which is just published, has a special, it's a special on health and social care, and it compares it from when it did the module 3 years previously, which was just when the HSE was set up, and it shows that pretty much in every area people are waiting longer for every form of the public health system. Increased charges. It's €100 to go into an emergency department now, unless you have a letter from your GP or you have a medical card. I heard someone rang me up recently of somebody, their sister, who went into Dublin hospital, didn't have the money in her wallet to pay the €100, had a sick teenage child, didn't have a card that worked, and they were refused entry into the emergency department because they couldn't pay their €100. Now, I had never heard that before, that people were actually being denied emergency services because they didn't have that cost. People in low income who don't have medical cards are now paying €120 out of their pocket if they're for prescription charges. That's a huge amount of money out of people's purses every month. Public hospital beds have got more expensive. Private health insurance, private hospital beds have got more expensive. So increased charges across the health system. And yet what we see is that these inequalities persist. And 2 examples of that is that quarterly household survey I mentioned asked, for the first time, broke people down by whether they had private health insurance, a medical card, or neither. And it showed that people who didn't have private health insurance, 14% of people without private health insurance, were waiting for a public hospital or public health appointment, whereas only 4% of people with private health insurance. So a very big, and that's population survey-wide numbers. So that's a huge gap between who has to wait, and it's the people who don't have private health insurance have to wait. Another area in cancer, and in fact the government has been quite successful in improving our cancer care in Ireland, and particularly our public cancer care. And in a way, what Tom Keane did was he nearly made cancer care one-tiered. And yet, there was an announcement about 2 weeks ago from Susan O'Reilly, the new head of cancer services, saying now that women in the public system were able to get this onco-type DX test, which decides whether you need, to what extent you need chemotherapy. It can have huge impact. Having this quite expensive test has huge impacts on determining what level of chemotherapy you have, but also on better outcomes. What you didn't see in that announcement was up to the 3rd of October of this year, women who were public patients only didn't have access to that test, whereas any woman who was it's only for breast cancer patient had got that test. So even in the bits of the system that are best or that are meant to be one-tiered, there's still these inequalities. We've also seen recent stuff around screening for cancer, and even though screening is absolutely population-wide, much higher uptake of screening and follow-up services among people with private health insurance versus people who don't have private health insurance, and some really good qualitative research around what's that about and how people don't believe they're going to get the care that they need and put off screening. So real inequalities that still persist. Am I doing time? Okay. Okay, I'm nearly there. I guess I have to mention the programme for government and the commitment that there will be free GP care for all and universal health insurance by 2016. And for any of us who've been concerned with and giving out about the inequalities within the Irish public health system for decades, this was a very welcome, positive, historic development that for the first time in the history of the state, a government is pursuing universal access. I think the how and the if this will happen is absolutely critical. Now, the ministers, the 3 ministers within the department, seem adamant that it is happening, and certainly Roisin Shortall, who's Minister of State with Responsibility for Primary Care, has said publicly in recent weeks they're going ahead with opening up GP care, free GP care to people on the long-term illness scheme next year and to people in need of high-tech drugs the year after, and that will be in place by 2016. Another thing that happened when the government came in was James Riley said he was getting rid of the previously, quite recently introduced prescription cards for medical card holders. And in preparation for this, I put a question into the department going, whatever happened at removing the charge for medical card holders? And I checked with my local chemist, and they're still charging medical card holders for prescriptions. And I checked with the HSE, and they said they were still collecting the money. And the Department of Health said, oh, it requires primary legislation. There's no legislation drafted yet. It's not on the legislative schedule, which means it won't happen this year, even though it was the first announcement Riley made when he came into office. And that it was subject to government approval. And I guess off the record, people in the department have said it's in there in the review of public expenditure, like everything else is, and it's up for grabs. So I think we do have to take a critical eye of what's been promised in terms of increased access to services if little things like that, which have been committed to, haven't been delivered on. So, in conclusion, we know that progressive tax systems and universal quality public services can help reduce economic inequalities and health inequalities. And yet what we've seen in Ireland is this absolute failure to reform the tax system. Even if we didn't have the banking crisis, which we had a crisis in the low level of our tax base. And what we're seeing now is this cutting rather than enhancing of public services across the board, evidence in cuts to special needs assistance for children with disabilities, and this rationing rather than expanding of the health services to meet demand. Another area where it's happening quite insidiously, I think, is in the Fair Deal, the nursing home support scheme, which was introduced meant to cover or pay for care for nursing homes for older people or those in need of it. And yet many aspects of that care is not covered by the scheme. Physiotherapy, occupational therapy, incontinence wear, medical appliances like wheelchairs, which in any other system of basket of insurance coverage would be covered, and they're not in there. Same with reducing the home help hours for people who we're trying to support living in the community. What that is doing is transferring the cost from the state onto the people to pay for vital aspects of that care. So I think the commitments in the programme for government around universality for free GP care and some model of universal health insurance are very welcome, and yet in the rest of government policy, whether we're talking about tax or social welfare or educational supports, or even the failure to take away the charge for prescription for medical card holders, we really haven't yet seen any evidence in the new government of any commitment to reduce health inequalities. I'll leave it there.
Okay, well, this presentation is based on a paper that's coming out later in the year in a journal called The World Economy, and it deals, today's paper deals mainly with the equity side of the argument, because when we're talking about issues to do with health and production of health, you could look at both efficiency and equity, because I think there's certainly no argument in my mind that there's huge efficiency gains to be made in health production, particularly in healthcare production. The resources which could be used then to eliminate some of the inequalities that Sarah just talked about. But I'm going to talk today mainly about the equity side of things, and mainly about the production of health itself, how health is produced, because it's a fundamental question in any society about what is health. Now, we're used to having the Department of Health and Children, but it's not really the Department of Health, it's the Department of Health Care. And it's not really the Department of Health Care, it's the Department of Acute Care and high technology care. And I think one of the things I want to try to explore is the nature of health and how health is produced. And I have to fundamentally deal with the issue that I suppose concerns us for many years, that is the questions of access. and differential access to healthcare. And one of the reasons that the universality has been welcomed is because it obviously promises that we'll all have equal access, and therefore that's a good thing. I argue it's a good thing too, but I argue that while it's necessary, it may not be sufficient to deal with some of the issues in terms of the production of health. And I want to talk a little bit about equality of opportunity and what that might mean in terms of allocation of resources and in terms of fundamental reform of how we think about health production. And in the end, I want to talk a little bit about caring communities, because this morning I just spent talking about caring communities and how we might think about the production of a health that's not often talked about, and that is health to do with quality of life, health to do with being excluded, health to do with loneliness, health to do with things like dementia, things that are outside of the sort of conventional discussions of health production. Because if you ask when I ask my undergraduate students to talk about health, they can talk all day about cancer and they can talk about heart disease, but after that then they stop thinking that health and health stops with heart attacks or cancer. So I want to talk a little bit about that in terms of how we might think about some of these. Okay, and I'm going to quickly run through some of these expenditure stuff, because I mean one of the things is that that in terms of our expenditure, I guess that as percentage of GDP, it's below average. As percentage of gross national income, Ireland is about 7th in terms of OECD countries. So we could have a fundamental discussion here for the next half an hour whether Ireland spends too much or too little on healthcare. And I'm not sure we get that many places. We know, for example, from the next slide, that if you went to the US, for example, and looked at the expenditure, you'd find 16% of gross national income spent on healthcare. And of course, we're used to these fundamental questions. Well, does it make any difference? We also know from the previous slide, just going back to the previous slide again, we know that there has been increases in healthcare expenditure in recent years. And of course that raised the fundamental question, putting my economics hat on me, well, what happened? What happened as a result of this healthcare expenditure? And I think it raises a really interesting question about some of the slides I'm going to show. When we talk about health being improved, or when we talk about mortality being life expectancy being extended, or mortality rates going down, the really interesting question is whose life has been extended and whose health has been improved. And I think that's as interesting as the overall figure in terms of the overall improvement. But I think it's important to talk about these at the start. The other issue, of course, that we have here, and I just put up the slide, not that you don't know this, but that the complexity of entitlement, although it has been improved in recent years and so on, we still have a relatively complex system, and it does matter what part of that system you're in. Whether you're a medical card holder, whether you're a non-medical card holder, whether you're on the margins of being a medical card holder, whether you have private insurance, whether you don't have private insurance, and all of these things matter in terms of access. And you can see the last figure there, that it also some people tend to want to pay out of pocket. They neither have insurance, and of course younger people have a difficulty in taking out insurance because with community rating, they're likely to be charged above the rate that they would have experienced. Now, if they were experience rated, now that is another really interesting 45 minutes about the issue of community rating and the issue of intergenerational solidarity and the issue of transfers between young and old, which is a different question. But I think we have to acknowledge that there's so many things happening within our healthcare system, within our health system, that it's very difficult sometimes in terms of its complexity, but also in terms of attributability, as to what causes what in terms of usage of healthcare system, or the non-usage of a healthcare system, or maybe it's something else entirely. Maybe the healthcare system matters a lot less than we think. And that's some of the issues I just want to raise at the end. So one of the things that I think is very important is to acknowledge in these debates that things are not all bleak, as Sarah mentioned earlier. We've had life expectancy gains and at both 0 and about 65, and we've had infant mortality gains. So there's been significant gains in terms of sort of overall health. There's also been gains from, in particular areas like heart disease, from some cancers, and there's been straws in the wind that sometimes paradoxically you hear European Health Consumer Index, for example, Ireland's ranked 13 out of 21 countries. Well, it's like any question, well, would you prefer to be 13th or 14th? Or 15th or 16th, you're never quite sure what these mean. But one of the issues is that some of the best results were on outcome indicators, some of the poorest in relation to e-health. But the point I'm making is, and this is a point I think that's important in terms of when we think about our healthcare system, is the people who get access to our healthcare system, the people who get care, generally have reasonably good experiences. It's the people who don't get care or who are on waiting lists interminably, or who don't have access to the best technology, or who don't get access to the best technology, or get access late, don't have that experience. So, when we talk about our health system, I think it's important to acknowledge the complexity and to acknowledge the nuances with respect to the success or failure of that system. And I do that in terms of paradox, the paradox we have life. Improved life expectancy, better health in some ways, and high consumer satisfaction sometimes from actual users, and with the EHCI noted Ireland seem to have a domestic marketing problem in relation to the healthcare system. Well, I suspect it's more than a marketing problem, but it's useful simply to point that out. And we have a continuous portrayal of the media system in meltdown. I just put that quote in to reflect almost all the time that we berate our health system as not our healthcare system. There's a difference, as being unsuccessful and therefore a danger. In fact, it's not a danger to the people who can get to the consultants, get to the technology, get to the beds that save lives. Where it is a danger to those who can't get there. So one of the things that comes up all the time, and one of the critical things that matter, is the whole notion of access and the whole notion of duality of access and separate waiting lists for private and public patients, and incentives for providers, for consultants to see private patients, and for hospitals to treat more private patients. And we're left with both the perception, but more so the reality of separate healthcare systems and the associated scandals. So this is a quick tour. I'm trying to be fair to the health system, a quick tour of the health system that we have right now. And so, one more point, because I think it's interesting because it's so important. A weak primary and community care. Even though we have, plans, and we've had numerous plans in the area I work in, we've had a really good plan for 20 years, but we didn't really get to do as much as we wanted in it. In terms of primary care, user fees more complex than in other countries, inappropriate hospital bed usage, particularly with respect to older people, sometimes there's nowhere else to go, a bias towards institutional care, limited supply of community-based service, and then the standard, ask an older person what they're entitled to, and they don't know. Because it's relatively complex, or used to be more complex. So this is the system we have. This is the promised reform. I'm getting to a conclusion here soon. Pardon?
3 minutes.
3 minutes. Right. Okay. That time travelled quickly. Okay. I better conclude then quickly. Okay. So the promised reform. You can see in front of you. I won't repeat that then. Point is, these are necessary but not sufficient. There's a poor understanding of health production. Equalising access is necessary but isn't sufficient. The important to me is equality of opportunity, and a failure to understand life course health. A failure to understand the dangers, the difficulties of poverty and inequality at an early age. An underestimation of the role of families and communities. And I don't talk about this as a cost-saving exercise, but an underestimation of the importance of communities and the importance of investing in health. Now, I'm not going to repeat all that, but you can see the life expectancy differences that Sarah talked about, standardised death rate differences Sarah talked about, traveller mortality differences that we know, and this leads us to sort of health inequalities similarly. This leads us to the relationship between socioeconomic status and health, and I think this is an area where we have least work done. This is the area where there's no complex or simple theory of socioeconomic gradients. Health affects socioeconomic status as well. Sickness reduces earnings. life cycle matters, and I think this is something that I think we need to build on. That life course matters, that life cycle, that parental resources matter, that childhood health matters, and they have cumulative effects and disadvantage across the life cycle. Education matters for the production of health, acting as a technology variable in the production of health, and for access, power and money seek out health improvements. Yeah, rich people tend to get the medical technology first, then it matters how quickly that's diffused. But the only thing where the new, in my view, where the new promises will actually help is in the latter. The possibility of easier access will mean that medical technology gets diffused faster. I'm not sure that the switch will help. My second last slide. The other area where there's a dearth of work, in my view, is the whole area of primary care, community care, and how you get health onto the production agenda within families and within communities. And this is where I think we can do a lot of work at relatively low cost, to talk about health production within families, within communities, individual responsibility, but also community responsibility in the area of dementia, and using organisations to actually talk about health, deal with loneliness, talk about inclusivity, to actually create an awareness, to create a fundamental, the importance of equality, the importance of dealing with subpopulations that are outside the process entirely of health production. That we're quite good at building hospitals, we're quite good at filling them with people who have bad behaviours. What we're not good at, is talking about health production for non-acute care, for people with dementia, for people with mental health problems, for people with disabilities, for people with depression who are outside of this standard model. And I think that's where a lot of the work has to be done in terms of health production. So the priorities then in terms of finalising this, I think public health has been underplayed. I think we've got an orientation towards private production and private insurance has fostered. I think we need to think about life course health production models. And that will mean making difficult choices. That may mean putting more resources, for example, into childcare, into early childhood interventions, rather than at later life. And these are difficult decisions, but in terms of if we want to maximise health, the focus on equality of opportunity for health, in providing opportunities for people to maximise health production, equal access to medical technologies. I think that's where the universal health insurance would matter. I'm not sure it matters anywhere else. Knowledge and education, where we've completely underplayed the role of knowledge in the production of health. So we focus on, again, the end stage, the cure, the acute illness, early childhood intervention, and community-based caring communities. And this is where we can use existing agencies. Health production is not just the responsibility of individuals. We've put a lot of emphasis on people to stop smoking because there's good evidence that matters. We need to equally talk about prioritising, different forms of intervention, that have equally good results in terms of impacting particularly on mental health, particularly on caring for older people, particularly for caring for people with disability. We need to build the evidence base for that, because it's not always clear, but I think there's at least tentative evidence, that more emphasis on health being produced rather than healthcare being delivered, can improve things for people. Okay, thank you very much.
Okay, I think we have about 15-20 minutes for questions.
Just want to say thank you to the three speakers for very informative sessions. And just go back, Eamon, to the very end, the way you summed up, 2 points I'd just like to make. One is in relation to that whole area of caring and the role of the carer and respect for the carer. And I think at this kind of time of drastic cutbacks, I just heard something during the week on a radio programme, and you asked earlier whose health has actually been affected. And it was this woman was asked to measure, she was a carer, to measure her mother's fluid intake and output in relation to how many pads she should receive for caring for her mother. Now, can you imagine just the pressure that puts that carer under? it actually affected me as just a listener to think that that's where we're steeping to. That's the first point. The second point is I'm a special needs coordinator in a DESH school. And it's in relation to early childhood education, but in particular in relation to young children and mental health issues. And again, the kind of cutbacks that are happening are actually having knock-on effects directly in this area. If you talk about cutbacks in relation to SNAs, you're actually talking about children with emotional and behavioural issues. And for a number of those children, there aren't actually outside agencies for them to access to get help in. And even where they can go to a clinic or whatever, it's checked out, maybe they're put on Ritalin or whatever, but there's no kind of other services to any great extent, and there's no linking between those services and the school communities. In fact, there's quite a division there because it's seen as a private area for parents, and there's no great link up there. And I think this whole thing has to link up, because I think we are, just in monetary terms, it's going to have a knock-on effect for the future economy.
Thank you, Chair. I was wondering, have you looked at the impact of housing on healthcare?
I'd just like to say that my personal experience of the health service through my parents and children has been generally very good, I must say. With the exception of the prime time programme that was aired earlier in the year, where I think it was in the Clontarf area, the care of the elderly was privatised, and it was just quite shocking how that took place. And I think they weren't under the jurisdiction of HICWA because of a legislative requirement. But the Achilles heel of it, and this is slightly a micro comment in this context, is that like when we see the strike there during the week where the nurses, I think it was in Limerick, went on strike, and I gathered through a friend of mine there was something like 40 people on trolleys, and I think the nurses just couldn't even keep up with it. It's a pity to see that the A&E thing, which we all can be liable to in terms of if you have an emergency, not everybody can go to Blackrock or the Beacon between 9 and 6, which is all very well as long as you get sick between 9 and 6 and you have the €100 or whatever. But I just was wondering, would you have any reflection on why it is so difficult for the health system to respond to the A&E crisis, which seems to be an Achilles heel? Thank you.
Thank you. My name is Sandra, and thank you very much for your input. I just wanted to get a kind of comment from you on the veracity of anecdotal evidence that the Fair Deal is actually undermining care to keep older people living independently, and is that something that is actually taking place? And also whether or not in encouraging private health providers to provide care for older people, the only growth industry seems to be private nursing homes in this country. Is that again something that has any veracity, or is it, is that true from your experience?
I might just take those questions. I know there's more hands up. We can take more in a couple minutes. Who wants to address?
I might start there. There's a lot there coming from you. Just in relation to the commentary in relation to incontinence, where I completely agree with you that there must be nothing more damaging of human dignity than to have anyone have to, ration or count or ration incontinence wear. And it's actually part of I got into terrible trouble with the previous government for saying this on air, that incontinence wear wasn't included in the Fair Deal. It's explicit in the Act. It's on the Oireachtas website, and I was told I was terrifying old people, and it was irresponsible and wrong of me. But it's not included. Now, in fact, the HSE had block bought incontinence wear for the next 5 years off some multinational company that happens to have its storage in Ireland. So they are supplying it for free, but when that runs out, technically, it's not being supplied. And that is happening a lot, is this sort of invisible stuff of rationing that's going on without it being explicit policy. I'll pick and choose between a few of them. Housing and healthcare. I think the Institute of Public Health have done some work on the impact of housing and healthcare, but certainly it wasn't something we managed to get around to in the TASC piece of work.
Just on that, there was a primetime programme on Dolphin House and the quality of the housing, and it was just appalling, the conditions people were living in and the types of ailments and health like asthma, chest infections, all sorts of ailments because of the quality of the housing. So
yeah, and also the work that you'd be aware of in terms of in relation to travellers. I certainly there's been great work done in Galway showing the direct links between very poor quality unofficial voting sites and very bad health. Carers, the privatised carers and the primetime programme you referred to, it's an example of the last government's policy. What they did was they privatised lots of things like nursing homes, and nursing homes were only regulated when there was the Leeds Cross prime time, and then they privatised home care, and it's still not regulated and won't be regulated for another year or two, but there is a commitment to do it. In relation to emergency department, people talk about the crisis in emergency department. There's been a crisis in emergency departments for, it was an issue in the 2001 general election. Liz McManus made it. So anything that goes on for 10 years is not a crisis. There's a systemic problem there that has failed to be addressed. It's failed to be addressed in primary and community care in terms of keeping people out of hospital in the first place. It's failed to be addressed in terms of move-on places for those within care, within hospital, which Amy referred to, the delayed discharges or bed blockers. So it's symbolic of a dysfunction across the system, but it's nothing. A crisis can't last 10 years. That's a systemic problem that needs to be addressed. James Riley, again, weeks in office, said there would never be more than 459 people on trolleys, as there were a couple of weeks before he became minister. Last week there was 471 people on trolleys on Wednesday, I think, of last week. And there are emergency departments across the country at the moment are dangerous places to be, because there's 20, 30, 40 people on trolleys, and those hospitals have 105% occupancy. That means that they're counting people who are sitting on chairs or on trolleys and halls. The World Health Organization would say anything over 85% occupancy is danger in terms of infection or control. So they really are dangerous places, many of our emergency departments. I completely disagree with Eamon's point that people who get care get relatively good care. I think the Irish health system is really hit and miss, and it's a lot of luck of whether you end up in a trolley or not in a trolley, or whether you end up in a ward with MRSA with an extra bed in it or not. And I think an awful lot of Irish healthcare is more likely to kill you than cure you. And finally, in relation to the fair deal, I don't think it's anecdotal at all. I think the fair deal, the way it was designed, it was designed to work for private nursing home providers, not public nursing home providers. The regulation that's put in place means, because of a lack of investment in public nursing homes, most public nursing homes won't be able to meet that regulation and will close. It on purpose is shifting care into the private, largely profitable nursing home sector, and by its very nature it's undermining people living in the community, because you do get pretty good financial support if you're in a nursing home, but if you're at home in the community without a home care package, you get no support. So the financial incentive is to push people into those nursing homes. I think I got some of them.
Danny, Eamon or David, would you like to comment on any of the questions?
I agree with the issue about facts are that private nursing home care has increased, the number of beds have increased, the proportion of private nursing care is much higher now. And I think one of the things about we have to be careful is that when we see when we talk about prioritisation and hospital and the trolleys and so on, there are also unseen need and unseen people who are not in the media or not in the news. There are 20,000 people with dementia, at least, who are not even known to the health and social care system. These are people living at home with carers who are silent, who don't have access to any health and care system. Now, we could stay here all day debating whether that need is equal to the need of somebody on trolley in a hospital. But I think it's just interesting again. It's interesting again, and this is almost pitting one need against the other. It's interesting that whose need is greatest. And I think there's also on the mental health side, there are people who again are, because of fragmented delivery, because of poor community care systems, who are again not part of the official system. So I think there's people whose voices aren't even raised, and I think it's important to remember those in health production. There is stuff on housing, the housing issue. I mean, there's issues on older people and housing. I mean, it's an important point, particularly, for example, in both urban and rural areas, where good social housing can mean huge changes in the quality of life of older people. And I think the places where that's done, it's been done really well, where older people have been brought together in social housing units. I think that's very important. And finally, we've just done work on 10 rural communities, north and south, looking at social exclusion, domains of social exclusion. And the results that came out being the standard ones, things like social connection, social resources, transport, income, and safety and security. And again, just want to emphasise that, in terms of health production, if you talk about production of health, if you measure health in terms of quality of life, in terms of all the things that make up a healthy life, if you're afraid in a neighbourhood, this is a really critical part of the production of health that has to be dealt with outside the healthcare system. And similarly, in terms of the sort of social care provision, I mean, there are cutbacks going on in home helps. For some people, home helps are the only connection they have with other humans. And I think it's really important, again, that when we talk about production of health, going back to what I was saying, that there's a wide variety of here that sometimes we only think of hospital production. And it worries me sometimes in terms of prioritization that even when we talk about need and we talk about exclusion, that's the only exclusions we see. But there are many silent exclusions.
I just pick up on that point. In the political economy of cuts, if you're a politician, what we've seen in the UK is you cut the areas where you don't have people howling back at you. And this happens to fall mental health services, people on the margins who need the help the most but are not organized to speak up. And if you're a politician, you're going to try to spread the cuts over time so that the consequences are really felt in the future. What we're seeing now is just the tip of the iceberg of a generation being blighted. What disturbed me when I looked at the data in Greece is that no one in Greece was paying attention. The data, the monitoring were all about finance. Guaranteed, people are slipping through the cracks in Ireland. The voices aren't being heard. I'd really like to see TASC or another body here try to consolidate data on what's happening so that these voices do get in the public forum.
Okay, two things. We're going to take some more questions and just going to excuse Sarah. She's got another engagement to attend to. So
Can I stay for one more?
Do you want to say one more?
Set of questions, yeah.
Okay. I think there was Bernadette and James, and Ruth and a few others.
My name is Bernadette McMahon from the Retention Partnership for Social Justice. I'd like to see a stronger link between income and health, because we've been warned that there'll be very severe cuts in social welfare. And the work that I do with communities, and these are communities consisting of people from different social economic backgrounds, but now I'm referring to people on low incomes. So much of the income must go on food. And what our big concern at the moment is that we're fairly early in the recession, but now children are being properly fed, but the families are not. So we're looking for where poverty is being camouflaged, and that will catch up on us. Now we're thinking of the single pensioner living on her own. She's making the choice because, as you know, all she gets is a living alone allowance to compensate for a second pension coming in. She's making the choice in many cases between food and heat. And so it's just that when we talk, and I know the reference was made, one person, the speakers made the reference to income, but I think we need to look and see not just the direct provision of help, but what else will actually impact on health. And then the other point, of course, too, is that when minimum income is looked at, there's very little sympathy for social exclusion and social participation activities. And yet that's where mental health is severely impacted. So I'm really making the plea that we never look at health in isolation only from its services, but we also look on income. Thank you.
I'm coming from another perspective. I'm concerned, very concerned, of the health of people who are in threat of losing their jobs and who are afraid of sharing what's going on in their own personal lives, who don't have the finances to go to the doctor, who are concerned, even when they're sick, to stay out from work in case it impacts on their job and whether or not their hours will be cut. The social effect in the workplace of people holding back information and not sharing information in case they might lose their job before somebody else. And this is a very real situation in the community and voluntary sector where many people whom I work with have had their hours cut by 50%. And in the last year, the number of stress-related illnesses that have come up because of that, and the fear of sharing these things because they're not sure that they will be able to pay their rent or pay their mortgage at the end of the day. And I think there is a serious cover on that illness and sickness that's happening in our society right now.
I just, if I may, go back to the issue of the accident and emergency departments and agree with everything Sarah said, and maybe just look beyond some of the things she said, just to highlight just how fundamental that problem is as a kind of a touchstone for what's wrong with the health system. If you don't invest in primary care and provide GPs with the technology and access to specialist services easily, then the only way they can access those services for their patients is to refer them to hospital. In the old days, when I was young, a GP could ring a consultant and say, can I have an opinion on this patient? I'll send them in tomorrow to your outpatients department, and they'll be looked at and referred, either admitted to hospital or referred back. Those days are gone. The only way you can get into a hospital now is through the accident and emergency department, and GPs just, they're quite blunt with their patients and say, I'd love to do something for you, but I can't. You better go up to accident and emergency and take your place in the queue. And then if you add to that the situations we have where we have the lowest ratio of specialists per head of population in the OECD, we have the lowest number of acute beds to population. We have one of the highest turnovers per bed, so it's not that people are staying in those beds too long. There's actually, they're very efficiently used. And we have a relatively high level of day case work. So it's not that the hospitals are not being efficient, but there is a huge capacity problem there, both in primary care and in the hospital service. What did the last government do about it? First of all, they said, some of the senior people associated with the last government said there isn't a problem, but what they did was they incentivized private providers to provide private hospitals, private technology, private specialists, which were accessed, of course, by people with private health insurance, the middle classes, almost a splitting of because one of the things we know from health policy that if you want a universal health system, the middle classes have to use it and defend it and make it their own. If it becomes, the public hospitals become hospitals for the poor, they suffer. If the middle classes are attracted off into private sector, everybody loses. So it really is, it's a fundamental issue that I hope that universal health insurance will address, but I fear it is these problems of capacity are not actually going to be addressed with the universal health insurance. Gets to my question, sorry for being so long-winded. Will universal health insurance, will it be the panacea that this government hopes it will be?
Hi, my comment is, my name is Evelyn Mulroe. My comment's very similar to that of Ruth's. You know, when I listen to Eamon talk about it's those who lack the opportunity to access healthcare or the health services or haven't had a good experience yet. I have experience of dealing with people with rare conditions, and there's 280,000 of them in Ireland. And I can tell you, when they access the healthcare system, they still have difficulties. And that's not about individuals within our system, it's about the system. And in terms of the lack of it, in terms of structure and organisation. And I think for patient organisations in Ireland, we're working together to try and influence change in that respect. But it's very difficult because the system within our legislative system is also slow. And we talk about, I heard our colleague from Cambridge talk about the importance of data. We don't have data in Ireland on healthcare, on people, on conditions, on diseases, patient registries. And I know the Health Information Bill is supposed to move towards that. But I think we've been waiting since 2009 for that bill to come in front of the Dáil. And that's where I move on to the whole argument about universal healthcare. You know, that would certainly help in terms of equal access for all people in Ireland, particularly those who have difficult chronic conditions or rare conditions or cancer or life-threatening conditions. But is it going to happen? Is our system able to change? Is the culture there so endemic that it's going to be a major challenge? And what do we as a society and as a people need to do? You know, I believe that Irish people have that rescue gene. They want to help those in need. There was a young woman who needed a transplant in London. The helicopter didn't arrive on time, and there was outcry around the country. But it's the system that wasn't there for that young woman, and it's the system that isn't there for many people that I engage with. So I just want to make that comment.
Thanks. Just let Sarah respond to those quickly, and then she's going to have to skip out.
Apologies, I haven't worked out by location yet, and I'm meant to be somewhere else right now. Brenda, I completely agree with your point, and the work that you and the Consent and Partnership do around the basket of goods, I think, is so valuable, because I think every year it does allow lots of us to make that case about the importance between income and health, and particularly that's why I put up that disposable income slide. It's not just about being able to purchase healthcare, it's about being able to purchase stuff to live on, and certainly that was part of the rationale for the TASC report, was for TASC to begin to make that link between income and health. I totally agree as well with the woman beside you. I don't know if people noticed this week is Mental Health Awareness Week, and there's that ad on television going, talk to somebody, and I just want to throw bricks at the TV screen, because if I am in crisis tonight in a mental health capacity, there's nobody for me to talk to unless I go to an emergency department. And if you go to an emergency department, you probably won't get an adequate emergency psychiatric response. So I think it's hugely irresponsible of them to tell people to go and talk to someone when there's a non-existent counselling or psychological service within the health system. The last two comments, I could stay all day, but I won't, because I've got to run. But I agree or endorse both of what you say. I think we are at this critical juncture in terms of universal health insurance. I'm not sure if the system can change, but they're promising change, or they're committed to change. I think we're at a juncture where James Riley wants to go one way, and Kathleen Lynch and Roisin Shortall want to go another way, and the Department of Health don't want to go anywhere fast, right? And if people want change, then it's up to us, or people, to influence that change and to support it going in what we think is the best option, because I think the current situation is unequal and unsustainable. You know, so I think we have to maybe take a bit of a leap of faith and try and steer it a certain way. And on that note, I'm going to run, if that's okay. I'm not very sorry to leave, but we are all late. Let's schedule for that.
David, do you want to make a comment in relation to those questions?
I think equal access is absolutely critical, and I think but it has to be built in with all the other changes we talked about, particularly in primary care. I mean, I think one of the things about primary care, for example, is I can't understand why the new primary care system, or rather it should utilise existing community infrastructure in the production of health. For example, you know, set up community meeting places for people that they can meet, that they can connect, that they can talk about things. That we're not using existing organisations, existing infrastructure. If we rely on GPs to run the primary healthcare system, we're talking about a health production model that's way off. because GPs can only do so much. And I think if we could link it into genuine community development, genuine community participation, including even organisations like the GAA, to have facilities and infrastructure that people could walk. I know when I go around the country, I know there's GAA pitches. Why not build walkways around these pitches for physical health? Yeah, so people in the country can walk around these pitches. There are so many things we bound up a proper primary care system, because without it, even if we have equal access, which is absolutely necessary condition. When I say the health system is good, it's very good for those who can actually, and that's why people take out private insurance, because they can access what they want. It's very good for people who can do that. But I think even if you have equal access, unless you have built in also all these other things, then it's going to be very difficult.
And just to echo Eamon's point, I mean, healthcare, I wouldn't expect wonders from a universal health insurance program. I don't know a lot about the details, but one thing that even Krugman points out, markets don't work well in healthcare, so I just hope there would be a strong public option involved with it. That got cut out of the US reforms. But healthcare in general is only a small fraction of what makes people healthy. If you want to deal with health, you have to start dealing with transport, the food system, the communities in which people, as Michael Marmot likes to say, age, born, live, work, and play. You have to start thinking about building a good society in Ireland. Maybe the crisis is a time to rethink the values and direction we're headed. There are also some opportunities that can promote health and raise revenue. These are tobacco and alcohol taxes that even the International Monetary Fund has recommended, and they face, of course, very strong opposition from industry, but also some other innovative mechanisms. Denmark just put in place taxes on very highly fatty foods and are using those funds to plow them back into services for vulnerable groups who have less access to healthcare. There's a really good point made about being afraid of losing jobs. I'm really glad you raised that, because the study after study finds being afraid of losing your job is worse for you than actually losing it. This economic uncertainty and anxiety can literally be a killer of ordinary people. Unfortunately, we're not getting any reassuring signals from the markets or from policy leaders about where the economy is headed. The other point about income, I think one of the big changes in income right now is the inflation in food prices. There was a bubble in housing, and there seems to be now another speculative bubble developing in foods. I understand Ireland has great agriculture. The problem is most of it gets shipped elsewhere, and it's driving up food prices here. And I think this is an area that hasn't been discussed. It's crucially important. Lastly, data. I wouldn't be a researcher if I didn't want data, but we have up to the minute, up to the millisecond stock market data, and the latest data we have on health in Ireland is often 2 years out of date, if it exists at all, more. So I hope that situation can be rectified.
Just to make the point again, I think it's very important that whatever pressure is put on in terms of prioritising production of health or better health, that the universality debate doesn't get captured by sort of the clinical medicine debate. That I think if we know we have difficulties with healthcare, we know we have difficulties in accessing technologies, but it is only a small part of overall health production. And I think it would be a shame if the opportunities for reforming the health system, not the health, get captured or get undermined by reforming the healthcare system. They're two totally different things.
Just I would like to make one or two comments myself, just in relation to the programme for government. It's a new departure in terms of setting out the ambition to provide healthcare that's accessed on the basis of need rather than income, which is new. And one of the vehicles they want to achieve that is with universal health insurance, and we've heard a lot of talk about the Dutch model, and just when we were doing the work for the TASC report on health, we looked at what's been happening in the Netherlands, and a couple of things are happening. One is it did provide more, a basket of services to more people, but they're having huge problems in terms of cost control. They're one of the highest in the Europe, but also because of the costs, they're now, what's happening is the private insurers are now being given permission to actually to reduce the basket of health products or services that they can access. So it's not it's been lauded as the answer to our prayers in some ways, but there's a lot of problems with it as well, in terms of even the fact that for a population of our size, is competing private providers the answer? So we recommended that a single state-led provider would be looked at, as well as looking at a mix of private providers, because as David said, markets don't work well in terms of providing healthcare, and that needs to be factored in. And just to say as well, the Department of Health, they are developing a public health strategy. It's called Your Health is Your Wealth, and they are attempting at least to look at other issues apart from health services. So they've sought submissions on that in relation to what needs to be put in place to have a healthier population and well-being. So TASC put in a submission, and it's available on our website. There's 2 questions I think I saw, Michael and Rhonda. So we might finish after these questions.
Yeah, just briefly, it takes up some of the themes that both in the questions and from the panel. I thought it was an excellent panel. It was always great when you come to a panel and you learn something, learn a lot from each of the speakers, so thank you for that. It relates to the data and public provision, because one of the few places you can find data on health in Ireland is outside Ireland, in places like the OECD. OECD Health at a Glance is in particular an invaluable document. And one of the things I noted from that is one of the things the OECD does is it plots the per capita spend on health for European economies versus things like longevity and so on. And if you abstract from that the Mediterranean economies, for obvious reasons that they enjoy better health than their spending would otherwise suggest, and despite Ireland's crisis, it hasn't slipped down to the Mediterranean. If you're taking the sort of Central and Northern European countries as a group, what's really clear from that statistical analysis is that there's a really marked difference in the outcomes, the health outcomes, dependent on who does the spending. I.e., if you take Germany and Austria, where health spending is actually quite high relative to the group, the health outcomes are low. And that's because a greater part of the health spending is done by the private sector. Whereas if you look at countries like Sweden and Denmark, and to a lesser extent Britain now, but still there, if you look at those, the outcomes are much greater than the average because a greater proportion of the spending is done by the public sector. And so I think it's quite key in any health reform to make that point, that ultimately, exactly as was said, that markets are not good at providing health. In fact, let's be honest, they're terrible. Because what they do is at every stage, like the United States, every stage someone is raking off a profit. And if someone's raking off a profit, then you have exceptionally high costs and generally pretty poor outcomes.
Thanks, Sinead. I just really want to echo something that Sister Bernadette said earlier on with regard to the kind of hidden poverty around health, and I'll be quite brief on it. With regard to people who are working on the minimum wage or a little or thereabout, who have absolutely no access to a medical card. And historically as well, for a lot of those people, and I include myself in those people from my own personal background, is we didn't tend to produce ourselves to a doctor's or to a hospital until we were sick. And at that stage, something had really gone wrong. So you weren't just going to get better, you were going to get fixed or going to see what way, you could deal with the rest of that. For God forbid, if you had TB, people just might figure out you came from a poor family or came from, and they may have been, and they were, as most of us in the room would be aware, a lot of the shame or the stigma that carried around us, unfortunately. And what Ruth said with regard to, again, it's these people, some of these people over the years may have had access to overtime
And with their overtime or with extra hours they earned, they put money aside for VHI. And in the last, particularly the last 18 months, people have looked, and VHI has come off the supermarket trolley. They're now trying to access the healthcare system as it stands. And as well as middle class, we're looking for people who come from a middle class background, or what we call a middle class background. It's until they're accessing the healthcare system that kind of end of it won't be fixed, which is wrong because, well, it's not wrong because these people have greater expectations. They may have access to VHI, so they know a level that certainly somebody who's on a medical card or paying for their own health, they wouldn't have the standards. They're just delighted to get whatever's handed to them. So we have to give for that reason, we have to give the universal healthcare system a chance, and we have to hope that it will work, and we have to hope that more and more people see some logic. I'm not a great advocate for private healthcare, I have to say, that some people who have come out of that system will actually fight viciously to retain it. I mean, we just have to look enviously, and we always do, at the NHS. That's kind of it. That's really what I want to say on that. Cheers, thanks.
Okay, going to wrap it up. I want to thank you all for your participation, and especially our speakers. So